right. Good afternoon, everyone. Good afternoon, Dr. Thrower. Thank
Good
you all
afternoon.
for joining us. So to all of our viewers, thank you very much for joining us today. I'm your host, Casey Minnis, Director of Communications for the Multiple Sclerosis Foundation, also known as MS Focus. And I'm joined today by our Senior Medical Advisor, Dr. Ben Thrower. Dr. Thrower is the Medical Director of the MS Institute at Shepherd Center in Atlanta, Georgia, and a recognized expert on multiple sclerosis. So today we're doing a town hall where we'll be taking your questions. We'll jump right into it. If you would like to ask a question, you can add it by clicking the Q&A button, which will allow you to ask your question anonymously if you choose. By sending it in chat, or for those of you who are on Zoom, you can raise your hand by clicking the raise hand button, and we'll call on you to unmute yourself. So I'm going to start right off with, we have a raised hand from Karen. Karen, go ahead with your question.
Hi, thank you, Dr. Thrower. Question about COVID and being on Kesimpta or a CD20 medication. I believe that I probably got a good reaction to vaccination. As of August, I had taken 3 doses of the Pfizer. But my question to you is, should I get COVID, or any one of us who's on this medication get COVID, will our body build natural immunity from infection? Because I know I had to go off my medication to get immunity from vaccination. Would my body be able to get immunity from natural infection as if, I weren't on the medication?
So that's a great question. And we're learning a lot as we've gone through this COVID pandemic. I would say that with the majority of our disease modifying therapies for MS, the medications themselves have not impacted significantly the way we think about COVID or vaccinations. The one big exception has been the B cell therapies, like you were mentioning. So this would be Kesimpta, Ocrevus, Rituxan, Truxima. These are all drugs that work on B cells in the immune system. And one of the major jobs of B cells is to make antibodies. So what we know from research is that some people on B cell therapies are not making a great antibody response to vaccination. The longer we can put between your doses and vaccination, the better. Like you were mentioning, sometimes people will take a break from their medication so that they can get vaccinated. Realize with vaccination or with natural infection, there are 2 immune responses. There's the antibody response from B cells, and there's a T cell response. The B cell therapies don't appear to have any effect on the T cell response to vaccination or natural infection. It's really that antibody response. So if you were on a B cell therapy and you got COVID, just like the B cell therapy can affect how your body makes antibodies to vaccination, I would speculate that it probably could affect how your body makes a natural immune response. So you might not get as much of an antibody response to natural infection. You should still get a good T cell response. The good news is we can measure antibody responses. So if you've been vaccinated and you want to know if you've got a good COVID antibody response, we can do that blood test. If you've had COVID and you want to know if you've got a good natural antibody response, we can do that blood test. So that is something that we are doing on a pretty regular basis. One of the other questions that comes up is there anything that we could do other than vaccination to maybe offer people on B cell therapies some protection? And this is not an FDA approved sort of thing to do, but there are MS centers around the country that are looking at using the monoclonal antibodies maybe as prophylaxis. So could a person on a B cell therapy get a dose of the Regeneron or the Evusheld or now I just have to look at the name of this one, the sotrovimab, We have to stand in the mirror and practice these names. So trovimab is of the 3 monoclonal antibodies out there, maybe the one with the best efficacy against the Omicron variant that we're seeing right now. So that is a thought. Could we give one of these monoclonal antibodies as a single dose, not to treat COVID, but to maybe try to give people antibodies if their B cell therapy is preventing them from making those antibodies? I would say if you're on a B cell therapy and that's something that you're interested in, talk to your team about that. There are a lot of kind of variables that go into whether that's a good idea or not. You know, every time we think we've got COVID completely figured out, it seems to throw a new little curve at us, with Omicron being the latest curve.
I have a follow-up question, if I may, for
Yeah.
those of us who are on the medication. I have on my own been going to Quest Diagnostics, and for $60 you can order a COVID test and find out what your antibody levels
Yep.
are. I don't know if that's the same as it is in research or in other institutions. My neurologist is saying that that's not an indicator. He doesn't chase those numbers. He says it's not an indicator of whether you have immunity or not. But after 2 doses of Pfizer, I was negative, no immunity. It was not at the 0.08 value that the lab had given it. And then after the 3rd dose, I was up into the 5 point something. And a couple of months ago, I did 4 point something with another test. Can we, as patients, be advocates on our own? And is this type of testing valuable?
I think it's perfectly reasonable. So and what your neurologist, I wonder if what he or she is referring to is, you know, the immunity to vaccination or to COVID is 2 parts. It's the T cell part and the B cell / antibody part. So by going and getting your antibody levels checked, you are looking at one part of that. In theory, there is a test for T cell immunity out there that is practically very, very difficult to get it done. So we've not been able to actually order that in real life. I don't see anything wrong with getting your COVID antibody levels checked periodically, you know, either through your healthcare team or doing it on your own like you're doing it. I think it's useful information.
Great. Thank you. Thank you. Thank you.
Okay, so you're muted.
Thank you very much for that. That happened because I switched over to email to read the questions that came in by email. What I was saying was that Julio had asked if there's anything new on alpha linoleic acid.
Yeah, so ALA or alpha linoleic acid is something that we think might play a role in either neuroprotection, remyelination, or have anti-inflammatory effects. I've not seen any recent studies. That there was stuff from a couple of years ago. I think ALA falls into one of those, into kind of the category of a supplement where there's a little bit of data saying it could be helpful. I don't see any big harm to using it. So if someone was interested in trying that, I don't think we have the data to say it absolutely does anything good, but I don't think it does anything bad either. And there's a little smoking gun there to say it could be of help. And that's an over-the-counter supplement.
Our next question that came in advance is from Katie. She said she's been looking forward to the Zoom. You'd helped her before. She's been on 100 milligrams of dantrolene a day, and it's working amazing. She says, I can walk unaided, and all the clonus and tremors have gone. My question is, what is the best exercise to strengthen my back and hips and legs, as I can't climb stairs and I have difficulty getting out of a chair too? Thank you, and Happy New Year to everyone, she says.
Happy New Year, and glad she's doing better. I think the question that she's asking, I would love for her to see a physical therapist and actually get some very specific recommendations for her specific situation. When you think about things like getting up out of a chair, walking, different muscle groups can be affected in people with MS. And one of the things a physical therapist could help us sort out is how much of her residual functional challenge is spasticity and how much is weakness. So if some of what she's interpreting as weakness is still a little bit of spasticity, that's going to send us down one specific path where maybe we're focusing more on stretching. Strengthening, yes, but stretching too. If it really is more of a weakness issue where she's got hip flexor, hip extensor weakness, a core weakness, that's going to be a very different exercise regimen. All of that said, all of us could do more stretching and more core strengthening. None of us have ever been hurt by, working more on our core muscles. And so, getting into something like an adaptive yoga program where you get some stretching and some core strengthening while she's waiting for those specific recommendations from a physical therapist, I think might be a good idea.
And the foundation can help with that. This year, through our health and wellness program, we're going to be offering classes 5 days a week. So we have yoga on Mondays. We have exercise on Tuesday and Wednesday, and dance on Thursday and Friday. All classes are virtual and all are done in a chair or done adaptively so that they're for every ability level. And we'll also be offering an art therapy class on Monday nights. So those exercise classes are available, and you can reply to your email that you registered for this program to ask me about that if you need any more information.
Very good.
Our next question is from Kathy. She says, are there any tests that can be done to ascertain if you need a B cell DMT versus T cell therapy versus stem cell therapy, or is the process just trial and error?
Yeah, the great question, and we would love to have that technology. The quick answer is we don't have that yet, that we would very much like to have that. We know from some work that was done at Mayo Clinic years ago that not everyone's MS is created equally. When you think about what drives a person's MS immunologically, some people appear to have MS that is more B cell driven. Some people appear to have MS that's more T cell driven. Other people seem to have this mixed pattern. If we had a way of knowing that up front, it would be wonderful, so that we could customize therapies to the individual. We're getting closer. There are groups out there working on that. The way Mayo Clinic got at some of this data was actually through lesion biopsy. People are not going to be signing up to have brain biopsies to help determine their therapy. So we need something obviously a lot more practical than that. But it is, she hits on a big need that we have not met yet.
Our next question is from Karen K. And let's see, it just slipped up out of my view when a new question came in. She says, I stopped my Ocrevus on 7/7/2021, switching to Mavenclad, probably starting in the spring. Should I hold off on the booster, or holding off on the booster so the shot is more effective? When do you think I would get some benefit?
Yes, so Mavenclad's a little bit different. And so what happens with Mavenclad is it's sort of resetting your immune system, if you will. So it's lowering the numbers of T cells and B cells, and those cells are coming back. We think that the B cells have probably reconstituted after your first round of Mavenclad, probably at 6 months. So I think you're absolutely fine to go ahead with booster dosing at this point.
Our next question is from Dee. She asks, I'm on Ocrevus. Should I be taking claritin daily to block ACE2?
Sorry, what was the last part of that question? To block?
ACE2, ACE2.
Yeah, that's a good question. I think it's a theoretical sort of question. So the idea with ACE receptors is that's the receptor that the COVID organism uses to enter our cells, and I just don't think there's enough data yet to say that that's what you should do. Again, if you can take claritin and it doesn't make you excessively drowsy or anything, again, I don't think there's any big downside to it. I'm just not, I wouldn't recommend it routinely. I don't think there's enough data yet. I get where she's coming from and it makes sense. I just don't think there's any data to back it up yet.
Our next question is from Christian. She says, my neurologist prescribed me 2,500 IU of vitamin D once a week for 4 weeks. Didn't check my vitamin D levels. What do you think about that?
I mean, vitamin D is really important in people with MS. We know that 85% of folks with MS are vitamin D deficient. I like knowing where you're starting and how you're doing with treatment. So I don't like blindly giving big doses of vitamin D. Again, I'd like to know what the pre-treatment level was and then follow those levels on a regular basis. Most of our folks, we check their vitamin D levels every 6 months with a target range of a 25 hydroxyvitamin D in the kind of the 50 to 80 ballpark for most people. So yeah, I think of it, so if they didn't check them beforehand, you certainly want to monitor them going forwards to make sure that you're hitting that target goal, and also that you don't overshoot. Vitamin D, like any of the fat soluble vitamins, so A, D, E, and K, can be toxic if you get too much. You get too much vitamin D, you start depositing calcium in places you don't want to deposit it, like in your kidneys. So you have a higher risk of kidney stones. So you do want to do the blood monitoring, at least now that you're on it.
Jennifer says she's 23 and was diagnosed last February. How susceptible are MS patients to other autoimmune diseases? I'm worried that I might have another autoimmune disease, but don't know if I'm being overly paranoid. Thank you so much.
Yeah, the data has been mixed on that. I personally think that if you have one autoimmune condition, you are at higher risk for others, that your immune system is kind of revved up, but the studies have been a little mixed. To make it a little more complicated, if you look at people with MS who get blood tests for things like lupus or rheumatoid arthritis, sometimes those tests will come back a little abnormal, and then you repeat it and it's fine, and you do it another year and it's abnormal. So it's almost like their immune system is kind of flirting with having another autoimmune condition, but they don't quite go all the way into actually making that diagnosis. So I think it's, if you have symptoms that are suggestive of another autoimmune condition, it's certainly something to keep in mind and get appropriate blood testing, because I have lots of folks who have, 2 or more autoimmune diagnoses.
Marta asks, are you aware of any reports in the medical literature or personally of blister formation several weeks after Ocrevus infusions?
I have one individual that we worked with that had some very unusual skin reactions with Ocrevus, and it was almost a blistering type reaction, and it would typically pop up weeks after the infusion. So when you think about Ocrevus, the molecule itself is probably gone within a week of your infusion. So it's not the drug that's sticking around, it's the immune effect that's sticking around. And that immune effect does last for quite a while, 6 months at least, if not more. So my general thought from just a common sense standpoint is that if you have a new symptom that pops up after you started a new drug and we don't have any other reasonable explanation, we need to keep an open mind and say, well, maybe that's a side effect of the drug, and skin reactions can be a manifestation of drug reactions.
All right, and Karen asks, so your patients who took Ocrevus for 4 years, how long do you typically wait before you transition to Mavenclad? Does it make a difference if B cells haven't repopulated?
So there's no time limit on Ocrevus. So you could take Ocrevus for the rest of your life. So it's not like you have to transition off of it. Typically we would think about transitioning off of a drug, including Ocrevus, if either the person's not tolerating it or they're having breakthrough MS activity, new MRI lesions, relapse, progression of disability. So there's nothing magical about 4 years. I mean, we have people who've been on Ocrevus for quite a while, or Rituxan even longer, because that drug's been around for quite a bit. So there's a fine line when you would like for someone to, see their B cells coming back, but maybe not fully repleted before you start something like Mavenclad. I don't want to give that person's MS a chance to rear its ugly head by letting them go back to a natural immune state. So I would probably start looking at that person's B cell numbers in the 3 to 6 month range and see if they're starting to come back. When they start to come back to, say, 25% of baseline, that's when I would probably go ahead and think about dosing with Mavenclad.
I'd just like to remind our listeners, if you have a question, you can use the Q&A button to submit it. You can choose to submit it anonymously or use your name. You can use the chat, or you can use the raise hand feature. And if you're listening on Facebook, you can type in comments and we'll try and catch your question there. We have an anonymous question. It says, regarding the COVID antibody test mentioned previously, which one is best for checking if antibodies have been created by either previous infection or vaccination? IgG, spike total antibody, or something else?
So a lot of times we don't. So I know for us, we use the Mayo Clinic, the COVID spike antibody test. I don't know right offhand what Quest versus LabCorp are using. So you have IgM and IgG. IgM is going to be your acute antibody. So that's what goes up immediately or soonest after vaccination or after infection. And then your IgG is what is your long-term protection. So really, you're more interested in the IgG. Yeah, I wish I knew specifically between the different labs out there which one they're using, but I would say we believe in the using the Mayo COVID spike antibody IgG.
And we have an anonymous question. It's how do you know when it is time to switch medications?
So I think to answer that question, I would step back and say, what do we expect from the medication? So we expect that you tolerate it, that you're not having significant side effects or lifestyle alterations. And then what we would like is an acronym called NEDA, N-E-D-A, no evidence of disease activity. NEDA is no relapse, no progression of disability, no new MRI lesions. So if you have tolerance and you're meeting NEDA, you're getting an A+ on your MS exam. Anything less than that, and we start having discussions about why is it that we're getting less than that? Could it be that the person's really not taking the medication? Maybe there's a side effect they're not talking about, and it's keeping them from being adherent to their therapy. Maybe they don't like coming into the infusion center every 4 weeks because it's a pain in the behind to battle with traffic in downtown. So if the person's not meeting those goals, tolerability and control of relapse, progression, MRI, then we start talking about, do we switch? When we start thinking about switching, part of that discussion is there something we would like a lot better? Is there really a great, reasonable alternative? If someone is on a highly effective therapy, there may not be anything that we like better, or the alternatives might have a side effect risk that's not acceptable to that person. So all those variables kind of go into that decision of when do we switch, what do we switch to. Ultimately, the person with MS has the final say, and a lot of that personal risk tolerance, do I prefer a shot, a pill, an IV, a lot of those things are going to get factored in also.
Our next question is from Jennifer. I want to preface this by saying there are no dumb questions, Jennifer. She says, I'm sorry if this is a dumb question, but do spinal lesions cause physical pain in the area that they're located in? MS can cause a lot of pain, but do the lesions themselves hurt on the spine?
Yeah, so typically the lesions themselves are not causing pain themselves. Now, that said, if you have a lesion at the spinal cord, you have nerve roots that come off of the spinal cord and supply skin at that level. So even though the lesion, it's not the spinal cord itself that's hurting, it's not the brain itself that's hurting from the lesion, you could still have pain at the site of where that lesion is because the skin, the muscle, the connective tissue that is supplied by that nerve, it may be affected at that level. So it's kind of a yes and no. So you can hurt at that level, but it's really not the lesion. It's not the spinal cord itself that's hurting.
Can you speak more to the causes of pain in MS, the variety of causes?
Yeah, so I think most MS pain you can divide into, it's going to be in one of two camps. It's either what we call central neuropathic pain. So you've altered sensation. So every part of our body is sending sensory information through the spinal cord to the brain to say, okay, am I feeling touch? Am I feeling cold, hot, pinprick? When you disconnect that area of the body, whether it's the hand, the foot, the face, from the brain will, we think, will make up its own information. There are a lot of ways that the brain kind of goes awry with sensation. It would be nice if with MS lesions you always just had plain old boring numbness, but a lot of times it's not just boring numbness, it's altered sensation. That altered sensation could be tingling, or I feel water running, or a bug crawling. If it's not painful, we call it a paresthesia. When it crosses into being painful, burning, hypersensitivity, stabbing, electric, zings, then we call it a dysesthesia. So that's all central neuropathic pain. And then we've got spasticity and spasms. So when you have increased muscle tone, that sort of chronic state of the muscle being tight can be uncomfortable. And then on top of that, you may have waves of spasm that can be uncomfortable for people. Most pain with MS is going to fall into one of those two camps. Neuralgias, trigeminal neuralgia, or facial pain, I kind of put into the more of the central neuropathic pain camp. Sometimes people with MS have pain that we don't know quite which camp it fits into. It sounds a little bit like some of both. So sometimes we're left with, okay, let's rule out other causes. Let's make sure there's not a musculoskeletal cause, a disc bulge, something else going on. And then we come back to, okay, we think it's MS related, but it doesn't fit well with either. Let's just start trying treatments. A lot of the treatments that we have might cover either base, both central neuropathic pain and spasticity spasms.
Okay, Jim says, hi doc, I'm in the infusion room now for my 97th
Right.
dose
You're
of
closing in
Tysabri.
on 100.
He says, my peripheral neuropathy and restless legs seem worse with the cold weather. Your thoughts?
So we always talk about heat sensitivity in people with MS, and we know that 70% of people with MS have heat sensitivity, but we don't talk as much about cold sensitivity. But I think it's pretty common, and so we definitely see spasticity and spasms act up. Restless leg syndrome in people with MS drives them crazy, drives us a little crazy too, because sometimes it's difficult to tease out true restless leg syndrome versus spasticity and spasms. Some of the symptoms are very, very similar. And again, if someone says their restless leg syndrome gets worse with MS, sometimes I wonder, is it really spasticity and spasms that are acting up more? But no, we hear you and we believe you. We know that those things do act up with cold. A lot of people with MS seem to have this very narrow temperature range where they have some things that act up with heat. We have things that act up with cold, and they feel best in kind of this temperate 70-something degree range. When my wife and I lived in Spokane, Washington, Spokane gets pretty cold, snowy winters, and we have about 2 weeks of hot summer there. We would have people with MS that would sometimes relocate over to the Seattle side of the state. They would put up with the dreary rain just because the temperature was more even throughout the year.
Lisa asks, there's currently talk of the future need for a fourth COVID booster. How do you feel about this?
I would sit tight for right now. Israel is publishing some data as we speak. There's so many variables in this, so many moving parts with this. As we develop vaccines, realize their current crop of vaccines were really developed to go after the original, the alpha variant of COVID, and they do look like they're very effective against the Delta. It looks like we lost some effectiveness with Omicron because the Omicron is so heavily mutated. So I would sit tight for right now until we get a little bit more data. If you are in the immunocompromised class, and really maybe I think for anybody, make sure you've had your 2 shots and your 1 booster for sure. But I would let the dust settle a little bit on a 4th, and let's see where we shake out. I think this Omicron variant you're going to see the case numbers continue to go absolutely nuts here in the United States because it is so contagious. The good news is it looks like it's mainly causing very mild disease. I would predict we're going to see the cases come down drastically towards the end of January just because of it. It's so contagious. It's going to burn through its fuel. And that's what it did in South Africa, went really high, came down. Then the question is, okay, now what? Are we left with Delta still? God forbid, hopefully nothing else spins out of some other weird variant. I think if we're lucky and God and nature do what we hope they do, this virus continues to evolve into something that's become more and more benign. Maybe it looks more and more like a routine coronavirus, a common cold virus. Omicron did appear to get some genetic information from other coronaviruses, some common cold coronaviruses. It's probably a good thing. So even though the numbers look really scary case-wise right now, I think there could be a silver lining at the end of this.
Let's hope.
Yeah.
Christian asks, I'm on Copaxone. How often do you recommend MRI scans? I have one every 3 or 4 years.
Yeah, so when people are newer to the MS diagnosis and they're starting therapies, you normally will get MRIs once a year. At some point, if people are just stable, year after year, they're clinically stable, their MRIs aren't changing, we do back off at some point. Nobody knows what the right number is. I'll usually go to an every 2-year regimen after someone's been stable for a while. If after, let's say they're doing 2-year MRIs, and those are stable, we'll put the option, maybe go into something less frequent, like 3 years. Again, personal preference plays a big role. I have individuals who dread getting in the MRI scanner. Their claustrophobia is so horrible that they would rather have a brain biopsy than an MRI. And so for those people, they're chomping at the bit to go to a 3-year schedule. Other people like the reassurance of their yearly MRI. It makes them sleep better at night to say, I had an MRI and there are no new lesions. So there are a lot of, again, personal preferences in there too. And where the science isn't, really absolutely settled, we give people with MS a little bit of say and some of those MRI frequencies when they've been stable for a bit.
Karen asks, it seems like I always get respiratory infection on Ocrevus, ongoing cough. But the bigger issue is my walking is getting worse at 65. Is it just the reserve tank getting low, or I'm just screwed?
Yeah, so the two different parts to that. We do see more upper respiratory infections as a potential side effect of Ocrevus. What their studies showed is those upper respiratory infections seem to correlate with, were more common in people with low IgG levels. So we do check IgG regularly, antibody levels. This is just general IgG, not COVID specific. IgG levels every time we do an infusion. There's a tendency when people have been on Ocrevus for a while for those IgG levels to start coming down a little bit. If they are low, that could be a reason why you're having upper respiratory infections. And one of the ways that we deal with that is we just lower the dose of the Ocrevus to let those IgG levels come back up. as we age as humans, we do lose neural reserve. And so when we hear someone say, you know, I'm 65, I'm on a really effective therapy, my MRIs aren't changing, I'm not having relapses, but I'm getting a little bit worse. We believe you, we know it happens, and we think what may underlie that is just normal human biology. As we lose reserve status, our brain's ability and our spinal cord's ability to adapt to old injuries like old MS lesions, we lose a little bit of that. What we need is a repair strategy. We need a way of putting your reserve status back up or repairing those lesions, and we are getting closer. And while we're waiting for technology to catch up with us to give us those repair strategies, we do know that reconditioning, getting you in as good a physical shape as you can be, is one way of pushing back on that loss of neural reserve. So again, if you've not worked with a physical therapist or an exercise physiologist who's very familiar with MS, for them to get you into a good exercise program, I'd really encourage you to do it, because it does help keep some reserve and let you roll with that natural human biology.
Physical therapy is so underutilized.
Yep, absolutely.
Jill asks, she says, sorry this is so long, but after stopping Aubagio in September 2019, I got a mouth ulcer and oral thrush. I've since been on Ocrevus and Kesimpta. The mouth ulcer went away quickly and hasn't returned, but I'm still dealing with the oral thrush. I took my last Kesimpta injection in September of 2021, and I'm waiting for Mavenclad to come. Yet, despite being treated multiple times by prescription and home remedies, the oral thrush is still there. What can I do?
Hearing that story, I would want to make absolutely sure that that's really thrush. You know, if her immune system is reconstituted, so she's off of a B cell therapy, you know, if the IgG levels are normal, if her T cell subsets are normal, and she's having what we think is thrush again and again, and especially if it's resistant to treatment, I'd sure want to make sure that someone has biopsied that, put it under a microscope, and make sure it really is what we think it is. I've seen situations where we have thought people had thrush when it was really something else going on. So I think that that's going to be pretty important, that she, especially heading into a drug like Mavenclad. Mavenclad's awesome. But one of the things that's different with Mavenclad is you take your doses, and it's not like it has such a long duration. It's not like we can take it back once we give it to you. So I would want to try to get that thrush or not thrush situation sorted out a little bit better, maybe before you head into Mavenclad.
What member of her medical team would she talk to about getting further testing for that?
I would probably go to an ear, nose, and throat doctor. Dentists sometimes get into that a little bit, but you want someone that can either scrape one of those lesions in her mouth or punch biopsy, something to put it under a microscope and look at it. And I think an ear, nose, and throat doc is probably going to be the best person.
Karen had a follow-up about the upper respiratory infections and you mentioned low IgG. She said, what is a low IgG level? What number?
Yeah, so it depends on the lab. Generally, when you get under 400 with most labs, that's considered to be hypogammaglobulinemia or a low IgG level. But again, it may vary a little bit from lab to lab. So 400 and above. I mean, I like to see people up and above 1,000. You know, I'll tolerate down as I don't like to see people getting much lower than 600 for my B cell therapy patients.
Katie asks, can you please tell me more about the MS hug? My last one over New Year's lasted 3 days, as it was intense and went on for a while. Is this a relapse or just another symptom that's come back?
I typically consider the MS hug to be a symptom, and by itself not an indicator that this is a relapse. Obviously, if you had an MS hug and you had new horrible weakness in your legs, that might change the way we think about it. But just MS hug all by itself, I think of as a symptom, and it's a symptom that's going to wax and wane. usually we think of the MS hug as being a form of spasticity or spasm. So it usually comes from a lesion in the spinal cord, and it's going to be this band-like belt, around the chest or abdomen, and it varies from person to person. It can be truly like a belt. We say hug like it should be a good thing. This is like being hugged by a grizzly bear, though it's not a pleasant hug. I think in some people, the MS hug can be a form of central neuropathic pain also. So if someone says their hug is mainly hypersensitivity to touch, burning, that may be more of a sensory symptom versus the spasticity. Spasticity is notoriously stimulus responsive. So something that knocks you off your game, sleep deprivation, stress, infections, those things make spasticity and spasms act up. So, if around the holidays, if it was crazy and family in town, if you had a viral infection, that may have been what sort of kicked this off for you.
Jim commented, MS hug is no bueno. Yes, yes, Jim, we agree. Jennifer asks, out of curiosity, why is it difficult to narrow down the cause of MS? And she offers a shout out to the diligent researchers trying to get us answers.
Yeah, so MS is multifactorial. It has genetic and environmental components, and nothing is absolute. So we know of over 200 genes now that put a person at risk for MS, and multiple environmental factors, low vitamin D levels, common viral exposures, and all of those things have to come together at the right or wrong time for you to have MS. And so you can have all of those genes. You could carry every one of those 200 genes and not have MS because you didn't have the right environmental exposure. We know that from twin studies. If you look at exact genetic copies of one another, twin A gets multiple sclerosis, twin B is going to get multiple sclerosis 1/3 of the time. 2/3 of the time, this exact genetic copy of this person is not going to get multiple sclerosis because they didn't have the right environmental exposures. So I think part of the reason it's a little bit difficult to pin it down is because there's so many moving parts in there. But I would say we know a lot more now than we did before.
Our next question is from Crystal on Facebook, and I'm not quite sure what she's asking. She says, what is a good vitamin D? I'm not sure if she means what is a good vitamin D level or what type of vitamin D that folks should be taking. So would you mind answering both?
We'll do both. So we would prefer vitamin D3 over vitamin D2. So vitamin D2 is ergocalciferol. So that's the plant version of vitamin D. It's a sort of a byproduct of mushrooms. That's the way they make that. The problem with, and you could take D2, it will get the job done. You're just adding an extra step in. So if you take plant vitamin D, your body has to convert that to animal vitamin D, vitamin D3. So you're losing a little bit in translation. We would prefer vitamin D3, that's cholecalciferol. So that is usually a byproduct of cold water fish oil production. So when they make fish oil capsules, that's where they get vitamin D3 from. They used to get it from sheep lanolin also, but it turns out that wool has become less and less popular. Little interesting fact: wool is almost worthless to farmers now. If you raise sheep, you pay someone to come in and shear your sheep, and they keep the wool, and they basically keep it for free. So for a lot of people, sheep is almost or at least wool production is money losing. So your vitamin D3 is what we would prefer you take. And that's going to be kind of a byproduct of fish oil production. The levels, again, when we do your blood testing, what we're measuring is a 25 hydroxy vitamin D level, and we'd like it to be in that 50 to 80 range. When you get your blood levels done, sometimes when we call our primary care docs, we say, hey, I had labs drawn last week, was everything okay? And then sometimes the nurse will say, yep, everything was fine. What was my vitamin D? It was normal. Don't be satisfied with just someone saying it's normal. You want to know the numeric value. technically anything above 30 is normal. So you could have a level of 31 and it's normal, but that's not where we want you if you have MS. We want you up in that 50 to 80 range. So get the number if you can.
Our next question is from Sandy. She says, my MS is with cognitive issues. It's 24/7. Is there anything that can help me with this?
Yeah, so cognition is one of those potentially hidden symptoms, but it's also an incredibly important symptom. We know it's present in about 65% of people with MS. It is a leading cause of vocational disability in people with MS. So even though it's invisible, it's hugely impactful. When we start diving into cognition, we want to step back and look at the bigger picture. There are other symptoms with your MS that will make your cognition look worse. If you're dealing with fatigue, your cognition is going to look worse. People with fatigue have poor attention and concentration. So we want to know about your energy levels, your sleep habits. Are you on medications that are sedating? We want to know about your mood. So if you have depression issues, that's going to make your cognition look worse. People with depression have poor attention and concentration. Sometimes we will try to improve someone's cognition by treating their fatigue or their mood and hoping we get a downstream improvement in their cognition. If we really want to know how someone's cognition is doing, we send them to a neuropsychologist to get formal cognitive testing. Full-scale cognitive testing is an all-day endeavor. It's going to give you a wealth of information about what's working well and where maybe you're struggling a little bit. I would say if you're looking at any vocational changes, asking for sort of accommodations or looking at disability, I would say you probably definitely want to get the neuropsych testing done. Speech language pathologists in many MS centers do cognitive rehabilitation. So they're part of that cognitive team. They may take what the neuropsychologist has done and then work with you on strategies to function better, or they may see you out without you seeing the neuropsychologist. The speech language pathologist may do a battery of tests, maybe not quite as intense as what the psychologist would do, to help give them a sense of where your highs and lows are and then help you develop some strategies to work with that.
So Ben emailed in a question. He just wants to clarify that you're saying that there's no maximum number of recommended doses for Ocrevus, that people are able to stay on it.
Correct.
Okay.
And I don't want to contradict what anyone's, healthcare team is saying. You realize within the MS world, there are a lot of different thoughts, but there is no hard line number of, when you say, oh, we've got to take you off of Ocrevus. Again, we mentioned earlier that there is this tendency over time, as people are on Ocrevus for years, for them to be a little bit more at risk for that hypogammaglobulinemia where their IgG levels will drop. But that's not an absolute contraindication to staying on the drug. We just adapt to it. We work with the dose if the person is doing well otherwise.
Our next question is from Robin on Facebook. She says, what do you think of stem cell therapy?
So we always want to clarify there are two types of stem cell therapy that in the MS world that we can think about. So there's the autologous stem cell transplant or hematopoietic stem cell transplant. So that's where you're rebooting your immune system. So with that procedure, you're going to take immature stem cells off from the individual with MS, do chemotherapy to basically wipe out their hard drive. You want to shut down this overactive immune system and then give them their own stem cells back, reboot a fresh immune system that doesn't have the memory to attack myelin or axons. So that's a really effective immunomodulatory therapy, probably one of the most effective things we can do. We've learned a lot over the years about HSCT. We've learned that there are people who are good candidates and there are people who probably are not great candidates. From what we've seen so far, the ideal candidate would probably be under the age of 50. They've got hot disease, so they've got relapsing remitting MS with a lot of active inflammation. People over the age of 50 and progressive forms of MS, the results have just not been as impressive. And we really want to think about the risks and benefits. Using high-dose chemotherapy to wipe out your existing immune system is not a benign thing to do to somebody. And as good as things have gotten, the mortality rate with HSCT is now close to zero. It's still a big deal to do that. Then there's the other type of stem cells that we think of as more reparative stem cells. So these are mesenchymal stem cells. So these are things that we're hoping would actually reverse disability by repairing damage in the brain and spinal cord. So the tons of research. We're doing a study here at Shepherd Center. Cleveland Clinic has a study going on. The Tisch MS Center up in New York has published some data on mesenchymal stem cells. So these are cells that are usually given intravenously on a one-time basis to try to repair damage. Nothing is FDA approved yet. We're very hopeful that one of these is going to work out. Where you have to be a little careful with both mesenchymal stem cells and HSCT is there are places that you can go outside of traditional research. So you may, with mesenchymal stem cells, we have individuals with MS who go to Costa Rica or the Dominican Republic, and they pay out of pocket for stem cells that are just, we just don't know what's being infused. And I get, if you're living with a chronic health issue and traditional medicine is not giving you an answer or not giving you a cure, it's very tempting to look outside of traditional medicine, and it does make people very vulnerable to being taken advantage of. HSCT right now in the United States, there is a study going on. Northwestern in Chicago was one of the bigger sites that was doing research. They've put their program on hold for right now. So it's very difficult to find somewhere in the United States to get HSCT if you wanted to do that. So people end up down in Mexico at Clinica Ruiz. They end up in Moscow. And again, you just have to do your homework and be a smart healthcare consumer, because I will say my experience with Clinica Ruiz has been that they're pretty indiscriminate. They will do HSCT on just about anybody that has the money to pay for the procedure.
And I should mention that you and a colleague have an article in the upcoming issue of MS Focus magazine that is directly discussing the types of stem cell treatment. And that issue will also have a firsthand experience from someone who has done the HSCT protocol. So if anyone has not subscribed, it is a free magazine that you can get through our website at msfocus.org, or you can reply to your registration email if you have questions. All right, our next question is from Karen V. She says, can you explain what smoldering lesions means and how it differs from other types of lesions?
Yeah, so we think with multiple sclerosis that you've got big fires and little fires. You have big fires that manifest as relapses or as obvious new lesions on MRI. And then we have smoldering fires that are kind of under the surface. So when we say smoldering MS, we might mean on MRI that we see a lesion that's just slowly getting a little bit bigger, or that just has a little bit of inflammation as manifested by enhancement on MRI, just around the edges. So it's not a big forest fire, it's just those embers under the surface that are kind of smoldering along. MS is interesting in that, you would think from relapses that MS is either on or it's off. And we know that that's not the case, that it can have low-level inflammation that is there most of the time. We think that low-level smoldering inflammation may be part of what drives disability. So there's a lot of push to say, how do we measure smoldering MS or smoldering inflammation? We need better MRI techniques, and we've come light years with MRI, over the years. And how do we put that fire out? There are two schools of thought in the MS world in terms of how we use disease-modifying therapies. Do we put people on a modestly effective drug, say like one of our old platform therapies, an interferon or a glutamer, and if the person does great, fine. If they have breakthrough relapses or new lesions on MRI, then maybe we move them up the food chain, or do we put them on a more effective therapy like an Ocrevus or Tysabri or Mavenclad right up front. A lot of MS centers have moved towards using those more effective therapies right up front. And part of the drive for that has been this fear of smoldering MS. For every big relapse that we see, is there something going on under the surface that we're really not seeing? And if we have someone who's newly diagnosed, is it better to put that fire out as effectively as we humanly can right up front versus waiting for 5 years down the line and the person now has, say, gait problems? You say, oh man, I wish we had been more aggressive up front.
Our next question is from Jim. He says, how often do you suggest cognitive testing? I was tested back in 2006, long before Dr. Godsell retired. Cognition is why I can no longer hold a job.
Yeah. So in a perfect world, we would do full-scale neuropsychological testing with some regularity. You don't want to do it too soon. There's something called practice effect with cognitive testing. So if you do full-scale testing too soon, people can actually improve because their brain has seen that format before. So it's been recommended that you probably put at least 2 years between full-scale testing. Then there's just the practicality of it. Full-scale neuropsych testing is expensive and it's an all-day affair for the person with MS. So we need something that's easier than that. So what we are doing now on a yearly basis, and we're just kind of rolling this out right now, is I was part of a task force that we looked at different quick screening cognitive tests. What can we do that's quick and easy in the clinic to give us some sense over time? And so what was selected was called SDMT, symbol digit modality testing. So the recommendations from this task force is that we do SDMT testing on an annual basis. So we are a lot of our folks have already kind of rolled into this program, but everyone, and hopefully everyone in the United States with MS will start getting SDMT testing on a yearly basis. If your SDMT is abnormal, it doesn't necessarily, or it's declining, it doesn't necessarily mean that it's your MS that's doing it. It's kind of the canary in the coal mine. It tells you something's going on. And it could be that your MS is progressing. Could be that we've put you on a medication that's causing some fatigue, and that's why your cognition is looking worse. But at least it cues us in that something's going on.
Our next question is from Karen K, and she says, sort of a two-part question. What do you think of Flexural as a muscle relaxer for spasticity? Twice I got Botox in my calf for foot drop. Not sure if I got too much, but I'm afraid to take it again because I fell 3 times after the Botox injection at 3 weeks. So what are your thoughts on that?
So Flexural is kind of more from musculoskeletal pain. It wouldn't be my first choice for MS related spasticity. Do we use it sometimes? Yes. Is it really specifically designed for increased muscle tone of central origin like we see with MS? Not really. So really your better traditional antispasmodics for MS are going to be baclofen and tizanidine, dantrium, things that we know work at the spinal cord level, whereas Flexural is something we think of typically more if I strain my back picking up my grandchild, something like that. That's not to say we don't try it, and it's worth a try. There's nothing harmful with Flexural. Botox is really effective for treating spasticity, but it paralyzes the muscle. So when you think about doing Botox, you want to work with someone who's doing those injections who has really said, this is the muscle that's the problem for you, and I think that I can temporarily paralyze that muscle without you suffering functionally. So if we get rid of spasticity by doing a Botox injection, but now the person's tripping and falling, maybe we hit a muscle that you really needed to use. And so that there's always that fine line between controlling the spasticity but not wanting to hit a muscle that you really need for daily activities. The good news with Botox is if someone does, if it's too much, if you end up functionally not walking well, or you've paralyzed a muscle that you really needed, it's going to wear off. It's not permanent. So normally Botox treatment is going to last you for about 3 months.
All right, we'll take one final question from an anonymous attendee. She or he says, do you have experience with MS versus low-dose naltrexone? Clinical studies seem to be mixed, but I used it very successfully for a comorbid inflammatory condition. However, it was hard to tell LDN's effects on my long-term RRMS, which is well managed with just diet, a couple supplements, and lifestyle.
Yeah, LDNs had kind of an interesting roller coaster. So there was a lot of excitement about it a few years ago, and then there was a kind of a counter movement where people said, no, it's just all a scam. And then UC San Francisco did 2 studies in secondary progressive MS and found that it seemed to be of a little bit of benefit. At least in the secondary progressive studies, people reported a slight improvement in quality of life. And when you broke down, well, what part of life improved in these individuals, it seemed to be either pain or fatigue that got a little bit better. So LDN, low-dose naltrexone, is going to partially block natural opioid receptors in your body. And the theory is that your body makes more natural endorphins, natural painkillers, to try to overcome that blockade. So it's not crazy to say, well, maybe you get some pain control by making more natural endorphins. We do know that the sort of the endogenous, sort of endorphin system does have a feedback loop to our immune system. So again, it could have immune effects. I'm okay with folks if they want to try out low-dose naltrexone. I'm not convinced that it is a disease-modifying therapy. I think of it as potentially a symptomatic therapy. Pretty benign. Typically, people are going to have to pay for it out of pocket, as we're using a non-FDA approved dose. But yeah, there's certainly literature outside of the MS world. There's literature in the fibromyalgia world, chronic fatigue syndrome. So there are other health conditions where they believe low-dose naltrexone could have some positive therapeutic effects.
All right. Thank you so much, Dr. Thrower, for spending the time today and answering so many questions. And I also want to take a moment to congratulate you and share with everyone the good news that last month your granddaughter Opal arrived happy and healthy.
Thank you.
Congratulations.
Thank you. That's grandchild number 2 for us. Yep. Thank you. It was a great Christmas present.
We're all so happy for you. To all of our participants, thank you for coming. Thank you so much for your many questions and your attention. If you missed any part of this teleconference, it will be available on the Foundation's YouTube page. It's also available on our Facebook page. And we hope that you'll join us next week. That's Thursday, the 13th of January at 3 p.m. when we'll have a presentation from MS certified nurse Sherry Binns on making the most of your doctor visit. And of course, we'll see Dr. Thrower again next month in February for his monthly program with us. So to all of you, thank you again so much for being here. Thank you, Dr. Thrower. And for now, we'll say goodbye.
Thanks, Casey. Happy New Year, everybody.